All right. Hi, everybody. My name is Keegan, and this is our presentation on radical belonging in healthcare. All right. So we wanted to start off by kind of giving our own definition for radical belonging before we get too far. And this is a lot of words, but there are some special things that I wanted to highlight, and I'll get to that afterwards. But what we define as radical belonging is the embrace of racial, cultural, linguistic, and ethnic heterogeneity in a group of unique individuals who can bring the culmination of their life experiences to society without a fear of judgment. This society of radical belonging is one that works with respect and purposeful understanding of its members to combat a world still harboring a systemic, self-satisfying circle of racism and oppression, unbreakable except by deliberate inclusion of the oppressed groups in the process of effecting change. Next slide. There are a few things within that definition that I wanted to especially highlight, starting with the heterogeneity in a group. Anti-oppressive work cannot occur without diversity in the team doing the work. For example, a Caucasian identifying team can't recognize or understand an issue in a system that disproportionately affects the African American community. Additionally, this idea of purposeful understanding and societal or social belonging isn't an individual entity. It requires a mutual respect and attention given to issues across communities. Every story is different, and belonging includes seeing each individual as having a unique experience or trauma, culture, history, tradition, or anything else that culminates in who they are today that we need to seek to understand. And lastly, deliberate inclusion of the oppressed groups in the process of effecting change. Those most affected by injustice have the most essential insights, and you need to include them in your groups in order to actually cause change. Next slide, please. And so when it comes to the importance of belonging in healthcare, this is important because it allows healthcare to completely center on the patient. When team members feel welcome, validated, respected, and heard, both laterally and vertically, they can communicate most effectively about patient care, thus improving patient outcomes and safety, as well as opening the door to continuous improvement in all aspects of healthcare. Additionally, different approaches to medicine and the art of healing can have varying effects for patients depending on the background and identity that they bring to the table. Patients who view prescription medications, for example, as poison are not going to benefit from harassment and belittling because they're non-compliant. Rather, a discussion on treatment options that align with their cultural values and can still address the biomedical concern is going to be a lot more effective. And finally, even how options are discussed rather than the options themselves can have an impact on outcomes. Having a diverse team and a predisposition to seek understanding of each patient as an individual rather than some essentialized experience paves the way for optimum care. Next slide. So with all of this considered, the intervention that we came up with was to create a lecture series on the experiences of medicine from the point of view of marginalized communities.
So outside of our intervention, we have recommendations to support radical belonging at mHealth Fairview in Montana. And the first one is to develop a healthier baseline procedures to optimize the community voice heard across all organizational key roles. And this would help to ensure that everyone feels represented by being seen and heard in the workforce, meaning that they're more likely to reach out to coworkers or even supervisors about anything that they see. The second thing would be to redesign the learning and training culture to be more cohesive and standardized while implementing any needed terminology to create more of a common language. And this is coming from a personal experience, as I recently started a new job at a hospital in which I am being trained by a variety of people who all do things in slightly different ways. It would have been more helpful to be taught why and how things were being done a certain way versus multiple different ways of, well, this is how I do it, and you can do it this way too, or you can find your own way. So this, how we would go about rating these implemented recommendations will be touched upon in the metrics section. Next slide, please.
The intervention will consider an equitable impact of COVID-19 by providing evidence-based lecture series that address the experience of disadvantaged populations. During the COVID-19 pandemic, these marginalized communities were the most vulnerable for misinformation, likely secondary to well-documented medical mistrust, Inequitably driven misinformation and mistrust around COVID-19 may deter or prevent individuals from seeking COVID-19 related medical care or just adhering to medical preventative care. And this is evidenced by the disproportionate health outcomes in minority communities. So our lecture series should include bridging the gap to address this mistrust, as well as addressing racism in medicine, and then framing the message that avoids placing blame on communities that are structurally placed at a disadvantage, historically speaking, social and economically speaking, and recognizing the underlying propagated disinformation and how that impacts this community. Next slide.
In order to thoughtfully consider each marginalized community, we'll ensure that a lecture in all of the series is led by representatives from each affected community. So for example, within the case, we learned about Kadra, who was of Somali background. She was Muslim and she was multilingual. We learned about Jessie, who was both lesbian and Latina. We also learned about Jonas, who came from an immigrant family. He worked in an environmental service job in which he had a lower salary as compared to his other coworkers. So this lecture series will address strategies to improve community conditions while also addressing these individual social needs and providing clinical care. We will also make sure to ensure that social determinants of health are considered throughout the series. These determinants of health are non-medical conditions in which people are born, grow, live, work, and age. These conditions are major contributors to the disparities of health outcomes for certain groups. And they include not only health and healthcare, but also education, neighborhood, and environment in which communities reside and work, social context, and economic stability. All of these we'll make sure to talk about within the series.
So education is a very clear focus of the lecture series, and we want to implement how diversity and inclusion is important within the field of medicine. So education on both all of language, ethnicity, race, gender, religion, nationality, and more will all be important within the healthcare team and the environment. And through education within the lecture series, we'll be able to build awareness to better understand patients and coworkers of different backgrounds. And this should help improve the relationship of the interprofessional healthcare team, as well as the patient to healthcare provider relationship. Further education on the benefits of people from different backgrounds, again, whether it be multiracial, ethnic, age, or sexual orientation, should help provide further awareness. And with increased staff diversity, it provides an opportunity to integrate the cultural differences in order to build a stronger yet more diverse community within the healthcare system. And with a more diverse community, you're able to promote further collaboration and spark additional innovation and creativity with the multi-dimensional backgrounds for a more holistic approach to medicine.
In terms of our metrics of success, our goal was to assess the efficacy of the lecture series in teaching a better interprofessional behavior, allowing for better relationships interprofessionally, as well as learning to be sensitive to other marginalized communities. Who we'll be asking is all the healthcare personnel who attend the lecture via a pre and post survey. The questionnaire will be administered prior to the lecture series and then immediately following the lecture series in order to determine the satisfaction and applicability of our results. Once our results are gathered, we'll run some statistical analysis, specifically in ANOVA on the scored survey, and we'll take those results and apply it to both the hospital organization as a whole, and then we can break it down into the different groups of individuals who took it. So all the way from the group to the individual level. Here is an example of an employee satisfaction survey that we found. As you can see, it will have individuals rate from strongly agree to strongly disagree based on the questions. This specific survey was designed for different hospital systems to personalize it for their own, which is something that would allow for more sustainability and allow us to more easily transfer to other systems. Some of the questions would need to be altered for our own purposes, but for the most part, this would be a very well-studied survey that we could do appropriate statistical analysis on. In terms of the sustainability and scalability, as I mentioned, the lecture series, the individuals who are participating have the opportunity to travel, or if not, we can do the lecture series via Zoom. The questionnaire itself can be distributed to each hospital system. This will allow us to gain power for our statistical analysis and provide us a better overall assessment of its efficacy and the sustainability for each system. Each healthcare system could bring in additional lecturers based on their hospital's needs. For example, if the hospital system sees a lot of patients of a Hispanic descent, they can have individuals from that community come in and further explain their personal beliefs, which would allow them to receive better care from our hospital system. And as I mentioned before, this would have a low financial impact because it could be done via Zoom. Therefore, you would remove the cost of travel for our lecturers. And finally, it will offer continuing education credits for the employees as an incentive for them to attend our lecture series. And those credits would only be given after the completion of our survey. So that would further help us gain our results.
So the take-home messages. While completing this series as well as working on this presentation, we were able to discover that effective teamwork in the healthcare system can help reduce the cost of providing care, reduce errors, improve patient care, as well as promote continued learning for healthcare professionals. Our lecture series is just one example of how we can promote continual learning for those healthcare professionals and hopefully overall increase that interprofessional collaboration. Another point was effective teamwork can also decrease the workload of individuals within the healthcare team. This is because each member of the team has a specific role that involves its own set of responsibilities. For example, if there was a patient who came in and we had to administer a test, we'd want to make sure that test was only being administered one time. Therefore, it's reducing the cost of machinery as well as for that patient. In addition, adaptability and communication skills are essential to effective teamwork. By having positive interprofessional collaboration, healthcare professionals are able to use all possible resources and knowledge to provide the patient with the best possible healthcare outcomes. Next slide, please. In conclusion to our presentation, this is our references that help us come up with the series that we decided to propose, as well as our survey and other statistical measures that we were used.